Good morning, everyone. Welcome to our 5th symposium, and I am very, very happy to be here with all of you in person and those of you who are joining us virtually. We are here to talk about health service engagement and the intersection of language and generation and cultural diversity, and it's really about communication. And I do want to take a moment to remind us all that, of course, violence is the antithesis of communication. Communication is complicated, and that is why we have an amazing array of speakers to talk about what we bring to our communications, which is about our cultural identity, our generational identity, and how do we interact with each other so that we serve the children, which is why we are all here in the first place, to have the best healthcare outcomes that we can have. So before we take our deep dive into all this discussion, I wanted to do a little bit of housekeeping. So we have factored in breaks along the way for the symposium for folks to take care of bladder hygiene, and you can check your emails so that during the sessions and with the speakers, you can be completely present. For those of you who are here in person, thank you. And we have boxed lunches if you signed up. And they'll be just outside the door at the noon break. And there may be posters from the medical students who did their Dean's summer research project, mentored by our own Dr. Maya Ragavan. But some of them had an exam, as it turned out. So you remember when you were a med student, life was chaotic. So if they can get here, they will have their posters on their research that they did around pediatrics and health equity. So please take a look at those at lunch. So before I introduce Dr. Ragavan, I want to take a minute to announce the winner of our 2025 JEDI Award, which is for joining efforts for dignity and inclusion in our community. And this year, the 2025 award goes to Dr. Onome Ogafabibi. So it gives me so much pleasure and joy in my heart and soul when I saw this nomination, because as I often say, Onome is the triple threat. I've known him since he was a resident, and he was a resident here and a fellow, and of course now he is faculty in newborn medicine. And he was nominated, by Jen Clays, the director of newborn medicine. And in her nomination letter, she stated, Dr. Ogafabibi is truly a champion of DEI efforts in the Department of Pediatrics and throughout UPMC. He is actively engaged in recruiting URM trainees at both the resident and fellow levels. He has obtained several grants to support his work in addressing neonatal and infant health disparities in the Pittsburgh region. This funding has resulted in the establishment of a NICU doula program at CHP, which is now being expanded to McGee Women's Hospital. He also participates in the fetal and infant mortality review with the Allegheny County Health Department to identify and address disparities in mortality rates. And he is very engaged with the community organizations, critically Healthy Start and the March of Dimes. So once again, please join me in congratulating Dr. Ogafabibi. At the end of Grand Rounds, we will be able to give Onome his very well-deserved award. And so now it is another true pleasure to introduce Dr. Maya Ragavan. Dr. Ragavan is the Associate Vice Chair for Engagement Research. When we were looking for someone to fill this position, we were very intentional about looking for someone who could elevate the research within our Department of Engagement. Maya's name quickly came to the top of the list, and one quick look at her publications and all the tremendous work she did and has done, of course, made it a slam dunk that we would want her to join us. I have so enjoyed working with her through these past few years. She is a fountain of ideas. She has boundless energy to take those ideas and put them into action it is in her research, it is in her work in the community, and very importantly, mentoring the next generation. She is an amazing force, and working with marginalized communities is really a big, big part of her driving force. And the second is taking that knowledge and dispersing it all over. Maya Ragavan is an associate professor of pediatrics in the Division of General Academic Pediatrics. She is a clinician scientist and a general pediatrician. Her research is funded by NIH, Office of Violence Against Women, and PCORI, and focused on supporting perinatal intimate partner violence survivors, engaging caregivers around dating violence prevention, and promoting language justice in healthcare and research. She is also an expert in community engagement, and in addition to being our Associate Vice Chair of Engagement Research, she is co-director of the Clinical and Translational Science Institute Community Engagement Core. She has won local and national awards for her community engagement and her advocacy work, and currently serves as the Public Policy and Advocacy Chair for the American Pediatric Association. Today, she will be discussing language justice frameworks to address disparities experienced by families whose languages are other than English for healthcare and research settings. Dr. Ragavan.
Thank you so much, Dr. Mateo, and good morning, everyone. It's such an honor to be able to speak to all of you today. So I'm going to be talking today about promoting language justice in healthcare and research. I have no disclosures, and I wanted to start by just expressing my gratitude. As you will see throughout this talk, this is truly a team-based effort, and these are just some of the many people, both here and around the country, with whom I've worked to do this work. And I feel really grateful to work here. There are so many people doing incredible language justice oriented work here in Pittsburgh and also at the Children's Hospital. And so thank you so much. In terms of what I'll be talking about today, so I'm going to start by talking about language-related health and healthcare disparities in clinical care and research. I'm going to define the concept of language justice, which I will pose as a framework that we can use to make sure that people who use languages other than English are receiving equitable services. And then I'm going to describe actionable strategies to incorporate language justice into your own clinical practice and research through use of checklists that I've developed with colleagues around the country. I want to start with just that this is a journey. I think no matter where you are in your journey of integrating concepts around language justice, I really applaud you, and I think it's just taking steps forward. There are many stories and people, both personal and professional, who've inspired my passion for this space, but I want to share one today. As many of you know, I do a lot of work in intimate partner violence, and before I went to medical school, I was an intimate partner violence advocate working at a domestic violence shelter. I remember speaking to a survivor of intimate partner violence who uses a language other than English, and she shared with me that every time she went to the doctor's office, her husband, who was also the person using violence, interpreted for her, and that she was never able to share her story with the doctor. She was never able for her voice to be heard by the healthcare system. And so her story really, I think her story and many other stories have inspired my work in this space, and I think started sort of my journey doing this work. I want to just also just level set some terms that I'll be using. So when I use the word translator, I am talking about written text or written communication, and interpreter, I'm talking about spoken or signed communication. Access to equitable communication for people who are deaf and hard of hearing is absolutely essential and critical. I'm not going to be talking as much about that today, but the principles that I'll be sharing, I think, can also be applying to people who use signed languages. So to start, we know that people who use languages other than English face health and healthcare disparities. And I wanted to start with this image, and this is an image depicting intersectionality theory, which many of you have heard of, but it's really how overlapping systems of oppression and power impact individuals. I say that because today I'm going to be talking about language injustice, but we know that language injustice intersects with experiences of racism and discrimination and xenophobia as well. And I actually really like this image of intersectionality theory because it focuses on systems of power, but you'll notice that language is actually not listed anywhere here. So I think this is a real call to action to make sure that language injustice is amplified and described as something, a type of discrimination that people are experiencing. I also just want to pause for a moment and think about the words we're using. So many people have probably heard of the term limited English proficiency, or LEP. There's been a move away from that term in order to try to be more strengths focused and less deficits focused in our language. LEP is often still used when we're talking about census data or disparities, but when we're talking about people's experiences in the hospital, I really like the terminology language other than English, which my colleague Casey Lyon has written about. And so that's what I'll be using. So if you see LOE, that's languages other than English. There's lots of other terms that people use. I know that Maria Say likes the term linguistically diverse, which I think is also really great. Languages of lesser diffusion is often used when the number of people who use a language in a certain region is lower. But I just want to be really thoughtful about the words we use. And as you'll see later, one principle and pillar of language justice is using strength-based and affirming language. Oh, sorry. So I want to start with just describing some of the disparities. And so there have been many studies that have looked at health and healthcare disparities experienced by people who use languages other than English. And when it comes to healthcare access or healthcare quality, as well as health outcomes, people who use languages other than English experience disparities in our healthcare system. So studies have shown that people who use LOE are less likely to have dual coverage with Medicare and private insurance on the adult side. They're more likely to lack a usual care provider. Children who use LOE are more likely to experience communication-related adverse events and medical errors, and have higher admission rates and days in the hospital. I thought this study was very interesting, which looked at infants diagnosed with bronchiolitis whose caregivers were Spanish speaking. And they found that those infants were more likely to have chest x-rays, CBCs, and blood cultures. Talking to a room of pediatric providers, we all know that none of those things are indicated in the case of bronchiolitis. And I think my hypothesis would be in that situation, likely there was the providers were not able to get a history. And so we're relying on things like lab work and x-rays, which are not indicated and could potentially even cause harm. There's also a study that was looking at EMS services and found that EMS services would triage at a higher level for people who use languages other than English. Again, I think the same thing, that they were not able to get a history. So we're triaging at a higher level, possibly providing care that was unnecessary for those patients. There's also have been a lot of studies about telemedicine. Telemedicine is such an incredible innovation in our healthcare system. It increases healthcare access. And studies both before the start of the COVID pandemic and during the pandemic showed that people who use languages other than English were less likely to access telehealth services. And this was in pediatric settings as well as adult settings. And there have been many studies on this, and I'm not going to categorically say that they all show this, but almost every single one shows that people who use languages other than English are less likely to be able to use telemedicine services. That really, I think, shuts out this incredibly innovative practice for a large group of individuals. So those are some of the disparities on the healthcare side. And I want to share now some disparities in terms of inclusion in research. So I'm going to talk a little bit about some of the studies that my team has worked on, but I want to start with this quote because sometimes people ask me, well, like, why is it important that we include people who use languages other than English in our research studies? This was a quote from a study that was where we were interviewing researchers about their perspectives on how do we make research more trustworthy. This wasn't specific about language, but I think it really is very powerful. So this person said, this was a researcher, and they said, if it's difficult to get members of those communities to trust me, then people think the easiest thing is just not to include them. The exclusion from research is not traumatic in the easily or usually defined sense, but it perpetuates injustice and it perpetuates a scientific self-delusion in the sense that we think that our results apply to all individuals, but we haven't included all individuals in our research. So I think that's a really powerful quote, and it really exemplifies the importance of being inclusive in terms of who is participating in research, to center their voices in science and make sure that our results are applicable and highly relevant. So the first thing that we did is we wanted to understand how, in pediatric research, how often are people who use languages other than English included? And so we did a systematic review of 3 major pediatric journals, JAMA Pediatrics, Pediatrics, and the Journal of Pediatrics. And we looked through 10 years of articles. So we looked at over 8,000 articles and included 5,000 of them that were based in the US and included human subject participants. And this was led by Annie Chen, who was a medical student. And we found that only in 9% of those articles were people who use languages other than English included. And then we did a deeper dive into that 9% to see how the authors detailed oral and written communication with those participants. And in less than 1/3 of those articles was any information provided. So just to kind of dive in a little bit more, so like I said, in those articles, only 9% of the articles included people who use LOE, 8% excluded. But what I think is really interesting and very stunning is that in 82% of the articles, language wasn't even mentioned. And remember, these are all articles where it's a human subject, human participant research. Language was not even mentioned in 82% of the articles. And then in terms of the 9% of articles that did include LOE individuals, only 22% described how oral communication occurred, only 13% described how written communication occurred, and 32% described what documents were translated. So it's less than 1/3 in general. And so I think this was really a huge, a call to action, both for my team and then hopefully more broadly to make sure that we are being thoughtful about how we include people who use languages other than English. But you can see that it's not just a matter of inclusion, it's how do we include equitably as well? How do we make sure that people have a seamless experience when they're participating in research? So to learn a little bit more about that, our team led by Dr. Schweiberger, as well as Yasmina Salib and Olivia Migliori, our team interviewed 30 non-English speaking members of the Pittsburgh community in these different languages, so French, Kisagua, Mandarin, Nepali, and Spanish. And we actually had community leaders do the interviews, and their experiences were so fascinating, we then interviewed them so we could learn a little bit more about what it was like to talk to folks who use languages other than English about research. And we found that, not surprisingly, but research is inaccessible often to people who use LOE, and the idea of research can be confusing. But many people said that if they could participate and they were able to have a good experience where everything was available in their language, they want to participate, they want to share their story, they want to be part of research. For the people that had participated in research, many of them felt like they didn't really understand their role. They weren't always sure what they were filling out or what they were doing. And then there was some mixed feelings about, trust towards researchers and research institutions. And I just wanted to share 2 quotes from this study. So I think this quote is really powerful. So this was a Mandarin speaker who had participated in research, and she said, "It seems like research studies all require that you are fluent in English, but that makes it awkward. How fluent do I need to be to say that I'm fluent?" And I think that really exemplifies how language is complex, right? People may speak or use languages in certain contexts and not in others, depending on your own identity, your own language identity. And so just because you can register for a research study in English or say that you want to participate doesn't mean that you can complete the whole study in English, and same with clinical spaces. And then this was this was from one of our community leaders who did the interview, who completed the interviews, and he said, a lot of them actually told me that, somebody somewhere asked them some questions, but it was in English, so they didn't really understand what they were talking about. And it was interesting because when we kind of dove in and talked to some of the community leaders, they were saying that they weren't always sure when somebody was talking about research that that's actually what they had participated in. Like they thought maybe sometimes it was medical care or something else. And I think that just exemplifies how people are sometimes participating in research and may not fully understand every step of the process. And then the last step of this kind of baseline work that we did was surveying researchers here at the University of Pittsburgh. This was led by Henry Hoffman and Tran Doan, who Henry Hoffman is a medical student and Tran was a postdoctoral fellow. And we surveyed 339 PIs and project coordinators, and we asked them what their perspectives were on including people who use languages other than English. And 50% of them actually said that they did include people who used LOE in the last 5 years, but 42% of that 50 said that they did it after the fact. So they had started a research study, they were doing their research study, and then they had a participant who was interested who didn't use English. So they sort of retroactively accommodated that participant rather than proactively planning for people who use languages other than English. And they provided a lot of recommendations. These are recommendations from researchers on how to ensure that people who use languages other than English, that their voice can be centered in research. And a lot of these, what I think was great is actually a lot of these are very actionable, right? Like, so they had wanted consult services, guidance with budgeting, greater access to interpretation, clear IRB requirements, which actually we have, which is great. And then information on finding language services. And so I have used this as a blueprint to develop some of the resources that I'll talk about a little bit later. All right, so now I've talked a lot about the disparities, and now I want to talk a little bit about how do we disrupt these disparities. And through this, I want to think about this idea of language justice, this framework that I'd like to share with you all. But before we do that, I just want you to consider the following story. This is a general pediatrics example because I'm a general pediatrician, but I'm sure that all of you can think of something that's also relevant to your clinical or research space. So you're taking care of a 2-year-old Lucas who was recently diagnosed with autism. His parents are native Spanish speakers from Mexico and prefer Spanish for their medical visit. During the intake prior to the well visit, where they're filling out forms online, his mom registers him in English. She is able to speak a little bit of English, and she registers him for the visit in English, and then she completed the rest of the visit in English as well. The office staff wasn't aware that she prefers Spanish, and she also didn't request an interpreter because she could fill out the form in English, and she didn't know, no one had told her whether interpretation was even available. But the clinic does actually offer free confidential iPad interpreters. So during the visit, she filled out the MCHAT form and the autism screening form in English. It identified him as moderate risk. The pediatrician spent a lot of time talking with the mom about a possible autism diagnosis, inviting questions, referring him to specialists. But then she's back today. She's very upset because she's really worried, understandably, about her child's speech and behavior. And today she brought an English speaking friend with her to help her communicate so she can be able to share her thoughts. And I just want to pause here because I'm sure as you're reading this story, you can think of so many similar examples that you've maybe encountered through your work. And I want to say that, there are so many things that are positive here, right? There are interpreters available. The clinician wanted to spent the time talking about the diagnosis, inviting questions, but obviously this isn't this isn't the result that we want, right? And this family did not get optimal care. And so this comes to this idea of language justice. And so I am distinguishing language justice from language access. People use the term language access a lot, and that's perfectly fine. If you want to use different terms for what I'm saying, that's okay. But the way I'm describing language access is the provision of language services to ensure that people can have those services. And language justice is rooted in addressing power imbalances and promoting the right to communicate in an individual's language to ultimately promote equity and social justice. And so an example I like to give to describe the difference between these two is language access is having interpreters available in our clinical space or for research studies. And language justice is creating a seamless process by which, from start to finish, somebody who uses languages other than English has language services, and they don't need to advocate for those services themselves. And I am all for empowering patients to advocate for themselves in the healthcare spaces. That is very much necessary. And I believe strongly in a healthcare system where you don't have to do that, where a patient coming in because their child is sick does not also have to advocate to have an interpreter, that those systems are built in and those processes are created so they can just focus on their healing and their child's healing and not on needing to advocate for their own language services. So to me, that is language justice, and that is where I'm hoping that we all continue to move. And I also just want to share that, language justice is a civil right. There are several federal laws that codify language access or language justice. The Title VI of the Civil Rights Act, Executive Order 13166, which reaffirmed Title VI of the Civil Rights Act, and also defined the extent and quantity of services and expanded language access to also federal agencies. The National Standards for Culturally and Linguistically Appropriate Services, or CLAS, which are 15 standards that healthcare systems need to meet around provision of language services. And then Section 1557 of the Affordable Care Act, which is focused on non-discrimination in health programs and really also details out more the need for interpretation and translation services. There has been a change in priorities and a change in administration. I don't know if anybody gets alerts or reads the Migration Policy Institute, but if you're interested in this topic, I'd highly recommend it. They have an article that was back in March, but after the executive order around English as a national language came out, kind of detailing what that meant. And the main thing is that it rescinded the executive order 13166. So I highly recommend reading it if you're interested. CLAS standards are still there. Just accessed the website yesterday and it is still up and still there, and the 15 standards are there. So I think I implore us all to continue advocating to make sure that language justice remains a priority at the federal and state levels. And when we think about language justice, I want to propose 4 key pillars to this approach. The first, which I've already talked about, is shifting the responsibility of provision of linguistically equitable services from the patient to the healthcare or research system. It is also the provision of language services throughout the healthcare or research experience from start to finish, which includes pre-hospital services, which could mean EMS or could mean calling in to schedule a visit. Convening a multidisciplinary language team, this work needs to be done in teams, and the convening of a team to do this work is critical, and then using strength-based and affirming language. So these are the 4 pillars that I propose for a language justice approach. And now, just make sure I'm not talking too much. Okay, so now I am going to share how to implement language justice. And I will start by saying that this is a very complex topic and I cannot share everything about how to implement this approach in 20 minutes. However, there are a lot of great resources here to support this work, which I will share at the end. So really the question has always been to me, how can patients, caregivers, or research participants have a seamless experience during their visit? And how do we utilize a systems level approach to ensure that language services are offered consistently and best practices are maintained? So colleagues at 4 different children's hospitals and myself, so 5 children's hospitals total, created these checklists. These checklists are not exhaustive. They are not the be-all, end-all answer to promoting language justice, but I really hope that they are a helpful starting point in ensuring that we are implementing a language justice approach. If you want to access them, their QR code should work. And feel free to email me. I also have this as a Qualtrics form if that's easier than the PDF. And I'm going to put them, I'll have this QR code at the end too. So now I'm going to go step by step through the language checklist and also bring in some of the research around some of these principles and why we created this. So the first step, I think the most important thing, is describing your language team. So as you're thinking about your clinical workflow or your research study, what team members need to be at the table. So it needs to be people who are going to be supporting spoken communication and written communication. And then really ensuring that people who use languages other than English and community partners are included as part of your work. So I think, as we all know, oftentimes, healthcare policies and protocols get created without patience. And so really thinking about how do we create these language workflows with people who use languages other than English. And then any additional other people, so community leaders, for research studies, regulatory folks, clinicians, front desk staff. So just making sure that you have your language team. And then looking over all the language related regulations that your healthcare system or research institute may have. And so UPMC has a lot, different policies. I'm still parsing through all, trying to parse through all of them. We do have a language access group that's run by Joy Jarrow at the UPMC level. And then we do have I have started to compile some of the policies around research as well. But there may be policies, for example, like family members cannot be used as interpreters. So it's important just to know what the regulations are. And then I recommend step 3, which is a clinical or research experience map. So this is really a step-by-step process mapping out the experience that either a caregiver or a research participant may have going through your study. And I think this is really important because it's very easy to forget a few steps. So I'll give you an example. The text message reminder of your doctor's visit. I know for me, if I don't get a text message reminder for my visit, I do not show up at said visit. And many people are the same, but those text message reminders are often in English. And I had a family once that had an appointment here in Lawrenceville. I see them in Oakland. They got the message. It was in English. They came to Oakland. They missed their subspecialty appointment in Lawrenceville. And so really thinking about every step that a patient and a caregiver may go through is very critical to make sure that we're not missing anything. And even if you can't provide language services for every step, that's okay, because you know what the steps are and you know where you may be missing people and where people may not be getting language services. This is a clinical map. And this is a research map. I did not create these maps. These maps were created by Olivia Migliori, who is a research coordinator on my team. If it were me, I would just draw it out. So you can do that too. But these are in Canva. And if it's helpful, it's a way to kind of think through the process. So after you've done that, then I recommend starting to think about spoken communication. And there's different ways to ensure language concordant spoken communication, either through a certified interpreter or a qualified bilingual provider. When you're thinking about spoken communication and interpretation, just as a reminder, there may be more than two, but there's two main types of interpretation. Consecutive interpretation, which is what we normally do in healthcare settings, which is, I speak, the interpreter speaks, the patient speaks, the interpreter speaks, I speak. Or simultaneous interpretation, which is like, what they do at the UN, where everyone has the headphones, and where there's, with a very slight delay, there is real-time interpretation services available. And so my recommendation is any group setting, it's very difficult for the non-dominant language speaker to be able to share their thoughts. If everyone's just speaking in English, the interpreter doesn't have time to do consecutive interpretation. So with group meetings, like, patient advisory boards or things like that, recommend thinking about simultaneous interpretation. I also recommend thinking about interpretation or language concordance services from start to finish. So this is work led by Lauren Yu, who's a medical student. We called caregivers who's in Epic, it said that they use a language other than English 2 weeks after a visit at a couple CCP site clinics, as well as the GAP clinic, and asked them about language concordance services, which here I'm defining as either a bilingual provider or an interpreter. And you can see that around 86% of folks said that they did have language concordance services with the clinician, but less so in other parts of the visit. And this is actually very similar to work that my colleague Casey Lyon has done in the emergency room setting at a different institution, which found, 89% of the time people had interpreters during the history and physical part of the visit, but it was much less, like 8 or 9% with medication administration and 3 or 4% with vitals. And so it's not something I would say specific here. It's very common to see that we don't have language services across the clinical workflow. And so I think this is very important to think about, how do we ensure that every part of the visit people have access to language? And then thinking about qualified bilingual providers. Ensuring that bilingual providers feel comfortable using that language with patients through competency testing or other things. And then just being really mindful about who we're asking to interpret, who we're asking to, act as a qualified bilingual provider or research coordinator, and never asking, students or trainees to translate materials without adequately compensating them. I can't tell you how many students I've talked to who have been asked to translate materials, and they have had to do it for free, or medical students asked to interpret. Those kinds of things are, we just need to make sure that that's not happening. Okay, and now I'm going to talk about step 5, which is written communication. So I think just in the past 10 years that I've been out of residency, it's just been remarkable the amount of increase in written communication that we have with our patients, right? Even just through the My UPMC messages, the My CHP messages. But while I think we have more embedded interpretation services, we have fewer options for real-time translation. We do have pre-translated documents, which are very helpful, but I know for me, what I really want to translate is, please take 5 mLs of amoxicillin twice a day for 10 days, right? Like those kinds of things. And so I think it's a really important opportunity for growth for healthcare systems across the country to think about how do we do translation better. This was a study that was done in 2019 of children's hospitals around the country. They asked the language access contact at different children's hospitals about what was translated and how they were translated. And you can see that about 100% of patients' Bill of Rights were translated, down to about 58% of information about community resources. And then in terms of how they were translated, 87% used pre-translated discharge materials. And here in 2019, 7% used translation software. I'm going to talk about AI and language for a little bit, but I would assume that that number may be a little bit higher now. But I think it just shows kind of the differences there. The one thing that I think is really interesting about this study is that they only surveyed the language access contact, and out of the 200 children's hospitals, 132 didn't even have a language access contact person. And so that's kind of buried in this study a little bit, but I thought that was actually a really, really important call to action and an important point, because these results are only of the children's hospitals that actually had a language access person. And then going back to the study I was sharing before, we asked people after their visit about written language concordance services, and 24% said they received the reminder text message in their language, 51% the after visit paperwork, and 34% completed a questionnaire. So those numbers are lower than interpretation, which is not surprising. It's very consistent with what other studies have shown, but I also think just continues to show the importance of translation services. Translation and interpretation are both very complex, right? It's very complex work. This was a study that looked at, basically what they did is they took a consent form. They sent the consent form to 4 professional translation companies. Then their team did a very robust kind of gold standard translation of that consent form, and they looked for the errors between what they did and the 4 that they sent to the translation companies. And they found the most frequent error was around non-equivalent registers, so problems related to difference in tone, formality, or verbatim translations of very culturally cultural terms or idioms or slang, which then when translated made no sense. And so I put this here to say that whenever we're translating, we really need to make sure that we're at the very least proofreading and pilot testing, because it's not necessarily that the meaning becomes altered, but the tone and the tone can become altered in the formality level, which I think it's very important that we're not doing that. AI translation. I could talk for hours about this, but I won't do that to you all. I will say, though, that please come, if you can, to the panel that we're having right after this talk, because we're going to be really diving in more to AI translation. But so this is the latest study I was able to find looking at AI translation and how accurate it was. So this was done out of Boston, and it compared translation of 20 discharge instructions. This is in the pediatric setting. It looked at what ChatGPT translation, Google Translate translation, and a human translator. And they found that Spanish and Portuguese were similar in terms of accuracy and fluency, but Haitian Creole had more clinically significant errors. The AI translations did compared to the human translations. And if you look at this over time, there was a study in 2016, 2021, and 2024, the accuracy just looks like it's increasing for ChatGPT and Google Translate, and now ChatGPT and other generative AI processes, but clearly is not always accurate. And the fact that there are clinically significant errors is very concerning. Our team interviewed pediatric providers and caregivers who use languages other than English here to learn more about perspectives around using AI. This was led by Gabriella, who's a medical student and will be on the panel at 9:15. And we found that it's used currently for written communication when no other options are available. And people were interested in it. Patients, caregivers, and providers were interested in it, but they had real concerns, very understandable concerns around accuracy, privacy, and empathy. They wanted to make sure that this was used only if it was properly vetted and integrated into clinical care. And I will let her talk more about this at 9:15. This is a fantastic paper that Casey Lyon wrote. If you're interested in this, this is a great starting point. I think she does a really beautiful job describing the nuance of using AI for language translation. But I think the long and short of it is not 100% accurate. You always have to have a human translator. It should not be used as our first line. And there's a lot of interesting conversation and opportunity, and I'm excited to talk about it more at 9:15. Step 6 is language preference documentation. So this is absolutely essential. We cannot provide language services if we don't know somebody's language, and we can't rely on just asking somebody if it sounds like they need an interpreter or they ask for interpreter. We have to universally ask everybody what their language preference is, both in research and clinical spaces. There have been some interesting studies looking at this. There's a study in the adult space that found that about a third of people who were EHR documented in Spanish wanted to take a screening survey in English, and a fifth of individuals who took the screening survey in Spanish were recorded in the EHR as English. There's incomplete overlap between language in the EMR language and participants' preferred language. And even when we did our study, we found that about 14% of people that we called said that they prefer English for their medical visit. But then when we dove in, some of those people were like, oh, I prefer English because interpreters take too long. I prefer English because my husband speaks English and he comes with me. So it can be very complex. And I think just making sure that we have systems in place to ask about language preference. So these questions are ones that Maria Say and I ran by a community collaborative, and they like these questions, which is, what language would you like to use with your doctor or nurse today? Or what language would you like to use for the research study? And free and confidential interpreters are available. And I will just say really quickly, from a research perspective, many of you may use Pitt Plus Me. It's an awesome resource we have here, which is a very large online recruitment repository. It's in English right now. And so in order to sign up for Pitt Plus Me, you have to be able to register in English. And I can't tell you the number of people that have signed up for Pitt Plus Me, have told us they're interested in a study, and we've asked them their language preference, and it has not been English, even though they were able to register for Pitt Plus Me in English. So for both research and clinical spaces, in order to really implement this language justice approach, we have to ask people's language preference. Maria Say has done some really amazing work in this space. She developed an intervention bundle that she implemented, and found an increase in the amount of people that were documenting language in Cerner after the implementation of this intervention bundle, but also found that there continued to not be 100% overlap between what was documented in EMR and what patients said that they wanted, or what caregivers said that they wanted during language rounds. And there was also not incomplete documentation between Epic and Cerner, which I know is not as important anymore, and continues to show that these documentation is not always accurate. So I'll say two things about documentation. Number one, pediatrics, what's so critical too is that we need to document the language of not just one caregiver, but any caregiver that brings their child to care, because every caregiver may have a different language preference, right? And the child may have a different language preference than the caregiver. And so I know it makes it more complicated, but I do think we need to find ways to document everyone's language preference and make sure it's very clear. And that we need to document people's both spoken and written language preference, because they may very well be different. And we don't want to be giving after visit summaries in a language that somebody does not read. And then step 7 is focused on training and education needs. So there's lots of different great trainings out there that can be provided for people to learn more about language. I want to share one thing. There have been studies that show that in high acuity settings, the emergency room in particular, during the busiest times of day, interpreter services are less likely to be used. And so I think building in interpretation or language into mock codes and simulation training is really important. So if that's happening, we already have practiced how to do that. And I think it is a really important part of language training. And then step 8 is resource needs. So what resources are needed to implement your language justice plan? So this is not an exhaustive list of resources. These are things that are available now. There may be other things as well, but I just want to share them. And then always please let me know, let others know if there's other things that will be helpful. So from a research perspective, this is what I have been working on with many other folks. We do have multilingual research consults available through the CTSI and the Department of Pediatrics Office of Engagement. You can put the consult through in either way. Right now, it just both comes to me. So you can also just email me, but we do have multilingual research consults available. We've created checklists like I've shown you and tip sheets. We have a yearly responsible conduct of research course through the CTSI that you can take if you want to learn more about research and multilingual research. United Language Group, which I think they've changed their name now to Proprio or something, but there's a contract set up through the University of Pittsburgh. So if you want to translate things, you don't need to create your own contract. It is not free, and I know translation is expensive, but I know the Office of Engagement has some funds, and there are some funds available to support this work. If so just let me know. And then there's an immigrant and refugee research practice partnership through the Pittsburgh study that I co-lead. So if you're interested in presenting your work to community partners, that's another opportunity. From a clinical perspective, because of the amazing Maria Say and many other people, Diego, many people here, many people, we have an incredible amount of clinical resources available, interpretation services, pre-translated documents. Maria Say has created these I Speak cards for patients and posters. There's training available. And then if you're ever interested in doing a similar QI project to what I shared, I'm happy to share the surveys. And many of you may also have done similar QI projects. So I think if we can all share together, then we can maybe replicate this in different clinical spaces. And just to finish up, I want to share one bigger picture policy issue as well. So while the federal government requires language services, not all states Medicaid, in not all states does Medicaid reimburse for interpreter services. So this is a paper that Dr. Schweiberger and I worked on that advocating or making to advocate for Medicaid reimbursement and also reimbursement from commercial insurance for interpreter services. And here at UPMC and Children's, like we do have those resources, but sometimes our colleagues in community spaces or our allied health colleagues, they are not able to have interpreter services or not able to use them because they are unable to pay for them because they can be very expensive. And I know sometimes like I'll try to, as just one of many examples, like I'll try to call a podiatry clinic and they don't have interpretation available. And it may not be for this reason, it may be for another reason, but it is really important that we advocate for interpreter services being reimbursed. It's a vital and life-saving healthcare service. So just a couple things that excite me. I'm not going to say gaps in the literature. I'm going to say things that excite me, things I want to work on, things I'd love to work on with all of you. I'm really interested in best practices around real-time translation services in clinical settings. I think this is a really novel and important area for growth. I'm excited to test different strategies to implement language justice approaches. So I'm working on some testing of these checklists. So if anyone's interested in using them and giving feedback, that would be great. How do we best document people's language preference for research studies? And then really thinking about the multi-generational approach. So how do we best document people's language preferences in pediatric settings with multiple caregivers and a verbal child? And then how do we do this work with community partners and as cross-sector collaboration? So many of us, we talk to folks in the education space, the social service space, they're asking really similar questions. So how can we all learn together and make sure that we, across services, we are providing linguistically equitable support? And to end, I'll just say language justice can never be an afterthought. When I talk to folks, sometimes people will say, I really want to include people who use languages other than English in my research, but like I already finished my budget and got the grant and started my project. And I'm absolutely thrilled to help you. And it is harder once you've created something to then try to make it in different languages. My recommendation is to always think about language when you're developing something, when you're developing your research proposal, when you're developing a new healthcare innovation, when you're developing a new clinical workflow. And if you think about language and include people who use languages other than English in your development, you absolutely will be implementing a language justice approach and improving healthcare outcomes for this community and disrupting these disparities. So thank you so much. I'm happy to take questions. And that's a QR code for the language justice checklist if you want to learn more.